For the next session, that is for retinal imaging, I would like to invite the chairpersons, Dr. Sabina Narang, Dr. Mohit Dogra, and Dr. Gaurav Sanghi on stage, please. And Dr. Ramandeep Singh on dais. The first talk will be on interpreting FFA and autofluorescence by Dr. Ramandeep Singh.
Very good afternoon, everyone. So, thank you, Dr. Suresh, for this wonderful program, which is, I think, it's the 12th PG teaching program this year. I've read that. It's a wonderful, sir. Congratulations on that. And thank you, Chair, for inviting me for this interpreting fundus fluorescein angiography and autofluorescence. I will just go to the I'll go straight away go to interpretation. I will not talk about fluorescein angiography. I'll assume that you know the theory. So this angiography is going on for a long time, and we get it done to see the health of the primarily the retina, and then it helps with the choroid also. Whenever we get a scan, this is where I want you to first, when I try to interpret a fluorescein angiography, this is what is important here. And can anybody tell what is written up there? Honey, honey. Is a song by Honey Singh? No? It's a name there. Alright, person's name there. And next is age. Alright, the patient's date of birth is given there. Okay? And down there is 23rd 11 2009. Any guesses? Date when the FFA was done. So this is very important. And down there ODOS, you understand? Alright, this is the right eye or the left eye. And what is this 005? So this is the timer. If that you assume that the photographer has started the time moment he touched that, the anticoagulant started injecting, and this is where first interpretation is about the timing when the arm is is getting injected into the anticoagulant vein or wherever he's pushing it in. This starts the timer, and then you will see the timing, and then you will see that whether first this dye is going to the retina, to the retinal artery, to the vein and recirculating on time, because there are certain disorders like artery occlusion, vein occlusion, ocular ischemic syndrome, where you want to know the timing, what is all happening, whether everything is, blockage is there, that is secondary, but what time it is reaching. So for that you have to know the various phases when it reaches there. So classically it's 9 to 12 seconds it takes to touch the retinal artery, and before that there is a phase called choroidal flush. When it is not there in the artery or the vein, you see this kind of a hue. This is your choroidal flush, and next within 2 seconds it goes into the artery. This is what we have been taught, and this is how it moves. Now within seconds it does some work, within 2 seconds. And next phase is it will go into the vein. Okay, the vein has it divided into, if you read the theory, early, mid and late. This is what early is. You see that classical laminar flow. You should read the theory yourself. But this is happening in 2 seconds. So 13 seconds in the eye, another, there's a range, 15 seconds, another 17 seconds in the vein, and then it goes into the recirculation phase. That means the artery vein constantly now washing out again to the heart, and again back, and after a few minutes it will wash it out. So these are the phases where what is important, that if you want, I want to know that something is happening to the optic nerve. I know the optic nerve is getting supplied from the choroid. I should have a optic nerve filling in the choroidal flush time. I know something about CRVO. I want to know that whether this vein is occluded or not, whether there is a kind of a, what do you call it, a CRVO which is indeterminate, or so I'm seeing a vein is not getting occluded, filled at around 21 seconds, so I'll call it a CRVO. This is classically, sometimes patient gets a scan with you, but this is the same thing, the pre-phases, arterial phase, mid phases, and the circulation phases. So, timer has the utility, as I've already said, when you are looking for the diseases where the filling of the dye is slow, RAOs, VOs, Takayasu's, your artery, your optic nerve, the ischemic optic neuropathies. This is where you want to see this. So this is one classical example where you see this the blood is like a bullet. If you are seeing a kind of a place there, if you are able to see this kind of a look here, that means something is wrong with this blood. It is slow. So again, you can see the timer there. This is again in 1 minute it has not filled the vein. So something is wrong. Whatever etiology is, your antenna should be up, that we have picked something on the fundus fluorescein angiography. Now once you move ahead, and the timer is taken care of, then you will, there are some clues which you should know that how a fluorescein angiography looks like when I'm seeing this eye, in these phases. And this is what is called normal. Apart from the artery and the vein and the disc, there is a retina there. How a normal retina will look like, it's a kind of a normal look. The moment we see something abnormal, there will be either darker areas or brighter areas. So darker areas always called hypo, and the brighter areas are called hyper. Now there can be various combination about it. So one is normal, one is hypo, one is hyper. So there are examples that what causes hypo. I'll just go on these hypo. So hypo is, so your fluorescein is there, so the something is between the fluorescein and you, and the retina and you. So fluorescein, that wavelength is not able to pass through the blood and into that photographer's filter, so it will be kind of a block there. All right, this is what you have to remember. Always interpret fluorescein with the clinical picture there. Don't call it a hypo there. Don't call it a hypo because of I'll show you the what. So this is a hypo due to the block. Your block is the blood. That is why you don't get fluorescein angiography in an acute BRVO patient, because you will not know whether this BRVO this blood is causing a blocked fluorescence, or there is a capillary non-perfusion due to BRVO. That is why you let the hemorrhages resolve in 8 to 12 weeks, and then you get an angiography to get a true picture. Is this hypo due to the capillary non-perfusion, or is it the blood? If you are have a good eye, you will be able to see that this black is more black than that other black I'm going to show you. So another black is due to there is something like this kind of a scar there, or there is a JFT pigment there which will cause a block there. So another one is, now this one is non-perfusion. So this is non-perfusion. All right. So if you will say that, sir, this perfusion is also same as block. No, look at this one. This is much lighter. All right. So if I don't have a clinical picture here, but this is due to the non-perfusion. Why non-perfusion? Suddenly these arteries and veins and have a kind of their path is stopped by something, inflammatory mediators or whatever, thrombus or whatever the etiology is, and it is not letting the blood go there. It is called the non-perfusion. So if there is no blood in the clinical photograph, so this is a non-perfusion because the blood is not able to go. So you will call it there's a problem with the artery and the vein. And then same, I told you primarily the retina, but yes, it can pick up the choroidal lesion also. So the artery is filling, but you can see these dark areas, because these dark areas, because of the choroid is also not getting filled. There are some granulomas in the choroid which are not being filled here, not filled here, filled here, not here. So you are able to see these kind of a non-perfusion because of the retinal vessels also, and in case of a choroidal etiologies also. We move on to hyper there. So hyper can be because of the various causes. The first cause is leakage. Hyper is, now you can make out a picture. Hyper, you are going to see something white there, something more than the normal there. So this is your I show you that hyper there. But this hyper, again, when you read about FFA, this hyper can be less hyper initially and become more hyper later. So this shows that whatever this tissue is getting more leaky. So this is leakage. All right. So this is hypo and more hyper. So this happens in the classic cartwheel pattern. We see that, we teach you in the CNVM case. So then there can be a staining there. So if you have a kind of this kind of a tissue there or a heel scar there, it can be a staining. Again, so there is a staining also, and there is a tissue which was hypo initially and becoming hyper later. So this is again a staining happening there. Now which is pooling. What do you call this? Pooling again. See, so you can see a big. This is exactly what we see in a CSR patient, or a patient where the pigment epithelial detachment is there. You have a dye leakage which is more than the what normal should be, but it becomes more in the late phase, and because it is remaining in this space only, this space is not going outside that space, so we say it's the dye has pooled here. And what is this swimming pool called? It's called pigment epithelial detachment. All right, so this is how a pooling will look like. Now there is something called transmission defect, which is also a hyper, but the classic is initially early phases the hyper is more, it becomes less later. So this is called a transmission defect, where you see this in case of you have a choroiditis patch, you have a scarring kind of a thing going on. So you will have a early hyper because of the the tissue there, and but later on it becomes less. So you will classically say it is a transmission defect. This is not something. So I go to the autofluorescence there. The autofluorescence I'll teach you in the next slide. This is what is happening. Again, there is a hyperfluorescence because of the various reasons there. So clinical utility in these cases, especially in DR, where you are planning to treat with macular photocoagulation, not with anti-VEGFs, you want to know what these lesions are. So these are the microaneurysms which are hyper and becoming more hyper. These are the microaneurysm hyper becoming more hyper. So you will treat them. Again, the neovascularization will appear hyper, and see the capillary non-perfusion area. Hypo and hyper in one eye together can happen. So you have to see, you're watching a diabetic, yes, we know that you can have a neovascularization of the disc also, and capillary non-perfusion, where you have to target your laser. Quickly, 3 slides about fundus autofluorescence. I will not go into details of this. Again, there are fluoropores which are in the RP which are being targeted in this investigation. This is a kind of invasive. FFA is highly invasive. You're giving a dye there. So it is, you are taking this kind of a picture there. So in this picture you are seeing all 3 kind of a lesion. ISO, I said, normal is called isofluorescence, and the dark is called what? Hypoautofluorescence, and the brighter is called hyperautofluorescence. So if a RPE is fighting a war, if it is normal, it will be ISO. If it is fighting a war, it is highly metabolizing to trying to save itself, it will be hyper. Moment it dies, it becomes a hypo. Simple. So this is where we use in all the RPE defects. So in a patient of a classic geographical ARMD, you want to see the clinical picture is much. This picture is much better than the clinical picture. Again, you want to see the progression there. All the hypo lesions all the islands are coming together, that means disease is progressing. This is where we use these most. We get in all the choroiditis patients, we get the autofluorescence, we don't get FFA. We see that all the lesions become black. All the hyper lesions will become black. They will never become ISO. Hyper to hypo is a win-win situation. We win the war. This is where we use the fundus autofluorescence in these patients. That was my last slide. Thank you so much.